Good afternoon, everyone. I think we'll go ahead and get started. I have 2 o'clock here. I'd like to welcome you all to our September webinar. We're going to be talking about, we're having an update on COVID-19. Dr. Kleiger will be talking about dialysis patients and the vaccines that are available. As a reminder, all of our lines are muted and will be throughout the program. But you can type questions or make comments in the chat box, and they will be answered at the end of the program. Within a week, the webinar recording and slides will be posted on our website. And we also ask that you complete the brief feedback form at the end to share your opinions and suggestions. I am very pleased today to be able to introduce our presenter, Dr. Alan Kleiger. He has been a presenter for us in the past, as well as he has written articles for us on the topic, and I just appreciate him a lot. He is a clinical professor of medicine at Yale University School of Medicine. He's a member of the Standing Renal Committee for the National Quality Forum, and he chairs the Nephrologist Transforming Dialysis Safety Initiative, a national partnership between the Centers for Disease Control and Prevention, that's CDC, and the American Society of Nephrology, ASN. He's the past president of the Renal Physicians Association. He serves on its Quality, Safety, and Accountability Committee. He's also past president of the Forum of ESRD Networks and has been actively involved in NIH projects. At this point, Dr. Kleiger, I'd like to turn the program over to you.
Hi, hello everybody. COVID-19, I think, has sucked the oxygen out of virtually any other issues and topics in medicine, and particularly in dialysis. And so we thought it would be helpful to just kind of take a step back and review what we know and where we are with this pandemic, and particularly what we know about how it's affected dialysis patients, with particular attention to talking about the vaccines, which is high on everybody's minds right now, obviously, and also to talk about the Delta variant and what that means in terms of risk and in terms of presentation, how that looks when patients get infected with that variety. You know, it's timely because just today, I know you've all heard that the CDC did approve a third Pfizer injection for those who got that mRNA vaccine for people over the age of 65 and for 2 other classes of people. One is people who have high contact with the public, such as healthcare workers, grocery workers, teachers, and educators. And also available for those at higher risk of complications should they get this infection. And that includes people with chronic kidney disease, and it includes dialysis patients. So just today, the CDC did approve, and the FDA has approved, a third Pfizer injection for dialysis patients in particular. So I do want to just talk a bit about what we know about this infection and about its variants and about and particularly about the vaccines. The particular areas that I'd like to cover in this talk, and incidentally, it will be a not a long talk. It will be a modestly long talk, taking up, I think, maybe 30-35 minutes. We're leaving ample time for questions and interactions, which I'm hoping that you will be willing and anxious to have with me. So the areas I'm going to talk about are dialysis patients at risk more than anybody else of getting infections. If you haven't been infected, and if you haven't had, never mind infection, if you haven't as yet been immunized, why get the vaccination now if you've held out up until this time? I want to talk about what vaccines are so that I'm going to try to give some science and some background into what really these vaccines are. There's been a lot of misinformation in the out in the media, and I think it's really important to sort of come back to the real facts of what we know about vaccines, what they are, how they work, data that we have about how well they appear to work for dialysis patients in particular. I do want to talk about what we know about this third dose, but the third dose, as you know, right now is restricted to the Pfizer mRNA vaccines. But what do we know about the J&J single-dose vaccine, which is not a messenger RNA vaccine, but something we call a vector vaccine? And I'll talk about what the difference is between those two types of vaccine and what that means. And then spend just a bit of time talking about this new Delta variant of COVID-19 and what that really means for all of us should we become infected with it. I want to start by a reality check. This is a graph that was just published in the New York Times a few days ago that shows the average daily deaths from COVID across the country in the United States compared to Germany, France, and the United Kingdom. And this is a snapshot of those average daily deaths over the last 3 months, from July 1st up until last week. And what you see here is that the average number of deaths per 100,000 population was about the same in Western Europe and the U.S. at the beginning of the summer. But over the last 3 months, as these months have proceeded, the death rate in France, the UK, and Germany went up very modestly, while the death rate in the United States went up to 3 times the death rate in even the UK, which is the highest level in Western Europe. So while all of us are tired of COVID and hearing about it, and while all of us had hoped this spring that we really were in the phase of improvement, declining infection, declining complications like death, this graph is a wake-up call. This tells us that the United States is particularly in trouble. And while it may be that these levels are peaking, as you see here, and the predictions are what we're seeing as 0.6 deaths per 100,000, or in other words, 6 people dying out of every 1,000,000 people in the United States, that this level may be peaking. It is where it is now at 3 or even 4 times the infection rate or the death rate for people in Western Europe. The risk of infection is higher among dialysis patients than in the general population, and there are several reasons for that. One is we know that older age is associated with higher risk, and the average age of dialysis patients has been increasing over the years, and now is getting into that range of, towards 65 years, which is the beginning of the substantially higher risk for contracting COVID-19. But in addition to that, other diseases that are common among dialysis patients, including diabetes, hypertension or high blood pressure, chronic lung disease, chronic kidney disease, all of these increase the risk of complications should patients contract the disease. But in addition to that, for patients who are dialyzed in center, there's an additional substantial risk, which is the fact that patients on hemodialysis can't isolate at home, can't hunker down at home like so many of us did over these last 18 months, and reduce our contact with people. Dialysis patients have to take transportation into dialysis centers, and for many people that means cars or taxis with drivers, ambulettes, public transportation, all of those obviously have a risk of increasing contact with people. And then in the dialysis unit itself, our dialysis stations were not built to be 6 feet apart from one another. And so finding ways of social separation is difficult in dialysis units. Now, I'm going to be showing you some data looking at what infection rates were like at the beginning of this pandemic in dialysis units, showing that these risks were real. And I'll also tell you when we get there, and I'll mention it again now, is that with the assertive work, the high work that dialysis organizations, companies that run dialysis units took to make sure that there was universal masking, universal personal protective equipment, careful hand hygiene and gloving, and clear separation of patients with COVID-19 or those who were suspected of having that infection from everybody else. With all of those steps, the incidence of spread of infection in dialysis units in the United States plummeted and now is exceedingly low. So the risk of contracting infection in the dialysis unit is remarkably low in the United States right now. But looking at early in the pandemic, let me show you some data. If we look back 18 months ago, first, these are data that came out of Western Europe and the EDTA, and it looked at the 28-day case fatality rates among dialysis patients. So this is if dialysis patients contracted COVID-19, and this is before any immunization or any vaccines were available. Among all patients in this study from Europe, if they contracted COVID-19, 1 out of 4 did not survive. If patients were well enough not to come into the hospital, only 1 in 20 did not survive. 19 out of 20 patients survived the illness. But among patients who were hospitalized with COVID-19, 1 out of 3 did not survive the illness. And among dialysis patients who were admitted to intensive care units in that era, back 18 months ago, more than half did not survive the illness. So this was a really set of frightening statistics before immunization that dialysis patients at risk, should they contract the infection, had a higher rate of life-threatening illness, a higher rate of hospitalizations, and a higher rate of death and not leaving the hospital alive than other patients with COVID-19. Doing an analysis in some of the areas of high incidence of infection was really interesting. These are data looking at the number of deaths among dialysis patients in ESRD Network 2. That's New York. And this was done in, as you see here, from February to August of 2020. This is right at the height in March, April, and then May of New York's huge pandemic that stretched the city's ability to provide care for its tens of thousands of citizens that were admitted to the hospital for COVID-19. So this shows that if you look at the number of deaths in the solid line, it rose from about 550 deaths per month in February up to about 1,700 deaths per month in the month of April, and then fell again by the end of May toward June. The dotted line shows what the number of predicted deaths would have been based on modeling that was done looking at the last 8 or 9 years of dialysis patients' deaths and seeing what one might see. So the dotted line at the bottom shows the expected death rate. The solid line above it shows the actual death rate. This coincided with this huge pandemic of COVID-19 in New York, So it's likely that the vast majority of the deaths that you see there above the dotted line were because of COVID-19. This is a similar graph looking at the whole United States from 2016 through August of 2020. Here again, this is the number of deaths in each of the months across the country among dialysis patients. And the solid line shows what the actual numbers were, and the dotted line shows what the predicted number of deaths were based on the modeling that I just showed you before. And you see in the years 2016 and 17 and 18, the numbers go up and down with seasons, with deaths highest in the winter months of December and January and February, coinciding with the influenza and other respiratory illnesses that happen in those months. And that the predicted number of deaths was really the same as the actual number of deaths you see until 2020. And in 2020, at the right end of this graph, what you see is that the actual number of deaths among end-stage kidney disease patients was substantially higher than those predicted. And that, of course, was almost surely because of COVID-19 across the country. So yes, COVID-19 is a real risk for dialysis patients and one that it's really important to do our best to protect against. Does COVID-19 spread in dialysis units? Well, here was a study that was done in London at the West London Dialysis Center before any immunization or vaccine was available and before widespread use of masking or widespread use of personal protective equipment was being used. It looked at over 1,500 dialysis patients. Of those, 20%, 1 out of 5, developed COVID-19 in this dialysis facility. Infection was much more likely in center than at home. Likely reason for that is people at home were socially isolated, were not among people who could potentially give them infection. More to the point, this study showed that there were clustering of infections on specific shifts in the dialysis units and in particular dialysis facilities. There was also high rates of nursing staff illness, and when this was looked at carefully, it became clear that in these units, COVID-19 was being spread from patient to patient, from staff to patient, and from patient to staff. As soon as the West London Dialysis Unit became aware of this pattern, they instituted universal masking, hand hygiene, surface cleaning, and personal protective equipment. And when that was done, modeling of these data showed that these measures substantially reduced transmission of infection. In a more recent study published a few months ago, a study looking at 51 London-based dialysis units from March to May of 2020. A total of 5,700 patients in these 51 dialysis units were examined. And they were looked for the outcomes of developing a positive COVID test or being admitted to the hospital for suspected COVID-19. In this group, 17% of patients tested positive and 8% of patients were admitted to the hospital with suspected COVID-19. So when those patients were looked at, those with the positive test or those admitted to the hospital, several features of that population stood out as risks of getting the infection. The first was diabetes. If you had diabetes in those centers, it was 20% more likely that you would develop COVID-19 than if you did not have diabetes. The community rate of COVID-19 infections was highly predictive of whether dialysis patients got the infection or not. And finally, the size of the dialysis unit was related. Larger dialysis units appeared to have less infection than smaller sized units, suggesting perhaps that patients who could be spread out in the unit had a lower chance of contracting infection. The important observation in this particular study was that in this study, age did not make a big difference in whether you contracted infection or not. Sex did not, ethnicity did not, isolation strategies did not. The only things that made a difference to making it more risky was diabetes, the community level of COVID-19 outside of the unit, and the dialysis unit area. Very interesting findings. Again, before vaccines were available, if you look at the experience with kidney transplantation, COVID-19 is dangerous for kidney transplant patients. This was a study published in the New England Journal of Medicine looking at 36 transplant patients who were admitted to the hospital with COVID-19, positive PCR tests for COVID-19. Looking at 36 consecutive transplant patients, 3/4 of them required hospitalization once they became infected. Of the whole group, 1/3 of them got sick enough that their lungs failed and they needed to be on mechanical ventilation. 17% of these transplant patients developed kidney failure and required dialysis treatments. And 1/3 of these transplant patients did not survive the illness. So COVID-19 is dangerous for dialysis patients, and the data are clear that it is also dangerous for kidney transplant patients. Which brings us to the modern era, the era since the beginning of 2021, when vaccines indeed became available. And the data are clear that the vaccines, as it says here, number one, they work in dialysis patients. The observations that have been done among dialysis patients since these vaccines have been administered showed that there is a marked reduction in hospitalizations. Many, many fewer dialysis patients who contract COVID-19, even if they do contract it after getting vaccinated, they have a very mild case and rarely need hospitalization, and even more rarely develop complications or death from COVID-19. This is a real difference compared to the numbers I just showed you before the vaccines were available. We also know that the vaccines are remarkably safe for dialysis patients. And while dialysis patients were not included in the original study population that the drug companies used to get approval of their vaccines, since they've been released, hundreds of millions of doses have been administered around the world with only mild side effects. Severe side effects of the vaccines are literally a 1 in a million observation. There have been some, but literally 1 in a million, where 999,999 people had no significant complications. And so be careful and don't be fooled by the lots of misinformation that's out in the media right now about risks of vaccine, because the CDC, the FDA, has been looking critically for any evidence here or abroad of complications and have found very, very little. Can vaccinated people get COVID-19 anyway? Yes. The likelihood of contracting it after getting vaccinated is much, much lower. It's reduced by a factor of probably 90 or 95%. And if you do get COVID-19 after getting vaccinated, it's most likely to be either with no symptoms at all, so you wouldn't even know you have it, or very mild symptoms similar to an upper respiratory infection or the flu. The vaccine is highly successful in protecting against serious disease or death. So if you've not as yet been vaccinated, the data are in clearly, and if you look clearly at the evidence is absolutely clear. The risk is high to dialysis patients. The vaccines are safe. They work at preventing serious complications or death. Get vaccinated now. Now, I want to spend just a few minutes talking about the vaccines. How do they work? And how do these new vaccines, these mRNA vaccines, work? Because they're different than the vaccines all of us got when we were children with the usual diseases that they try to prevent. So this cartoon shows the common diseases that we all have had, like measles or chickenpox or influenza. These are all viruses that are easily contracted. And our bodies fight those infections by developing antibodies. Our immune system reacts to getting infected with these organisms by developing antibodies. And those antibodies are proteins that circulate in our bloodstream. And if you get infected with something that you've had or that your body has seen before, like in the upper left-hand corner, should you be exposed to the measles virus after you've had measles and developed antibodies, then those antibodies recognize the measles and the little spike antigens on the measles viruses, and they latch on to the measles, and they pull it out of the bloodstream, and they destroy these viruses in the body's immune system. So when measles or chickenpox or influenza comes and is recognized by the body as having antibodies already there, they latch on, get rid of the viruses before they can cause any significant disease. In the lower right-hand corner, you see if there's a new virus that the body has never seen before, there is no antibody there that's ready to latch onto it. And so the virus escapes the body's immune protection, multiplies in the body's cells, and causes the disease. Now, one of the things we can do to try to prevent that from happening is to help the body to develop antibodies, but develop those antibodies not by looking at the whole virus the way you do in a natural infection, but rather in this cartoon, looking at the green slot on the left of this antibody molecule. This little green slot on the left-hand side, you see, is the part of the virus that offers immune protection. And if we can somehow get that little piece of virus to make the body make these new antibodies shown in those green, that little green Y, then those antibodies can be present if a virus ever were to appear. The body thinks it's seen it before because they've seen that little piece before and will attack the virus and get rid of it. And that's the whole point of the vaccine. The vaccine is done to provide a way for the body to recognize a little piece of the virus. It's not a virus. It's not alive. It can't multiply. It can't cause disease. But it's there to be a target for our body's immune system to recognize it, to develop an antibody, and to be ready in the blood to attack should the actual virus ever come. So here's a series of cartoons that show how these so-called mRNA COVID-19 vaccines work. So let me just run this through from top to bottom here. Underneath the spyglass that you see toward the top of this cartoon is the spike protein located on the surface of the COVID-19 virus. That's a protein that is the target of developing antibodies to try to destroy that virus. So if you get infection and you've never been immunized, your body develops antibodies directed against that spike protein and then can pull the virus out of the circulation and destroy it. What mRNA vaccines are little tiny packages of messenger RNA which is a genetic material that tells your body how to make proteins, how to make antibodies. So these little tiny pieces of messenger RNA, and that's messenger RNA that tells the body how to make the spike protein, how to make this little teeny piece of spike protein. The mRNA little tiny pieces are put into a protective lipid capsule and injected into your body. That's what the mRNA vaccine is. When it is injected, that little bit of mRNA goes to the cell and tells your cells to make antibodies directed against this spike protein. The cells, then, your own body cells, destroy these little vesicles and get rid of that messenger RNA. But what you're left with is antibodies floating around that are there in case COVID ever appears, will rapidly recognize it, latch onto it, and destroy it. So the mRNA vaccines work by having little bits of mRNA that instruct your own body on how to make this little piece of protein. It's not a virus. It's a little teeny piece of the viral coat, but it can't multiply. It isn't a virus. But your body sees that and then makes antibodies against it, and that is what protects you against any possible infection in the future. The vaccine does not contain virus. It's not alive. It cannot replicate. The vaccine cannot cause COVID infections. It's a tiny piece of mRNA that teaches our cells to make copies of this spike protein. It cannot make a whole virus. It just can make this little teeny piece of spike protein. These copies of the spike protein stimulate our immune system to make antibodies to the COVID-19 virus. The antibodies pull the virus into the immune system and destroy it, and so we don't get serious COVID-19. The cells break down the vaccine after it does its job. The virus does not enter our cells' DNA, despite what lots of misinformation has said. That little tiny piece is destroyed and has no life after its initial instructions are given. Okay, so how well do dialysis patients respond to 2 doses of the mRNA vaccine? AICP, the government organization that looks at this, made this slide showing several studies showing what different groups of patients, how they respond, how they develop antibodies against COVID-19. The dotted line shows what normal people do, which is 95% develop antibodies. A very, very high percent develop antibodies after immunization, after vaccination. You see the green circles, the hemodialysis patients, cluster right around that same place, do very well, make lots of good antibodies. Compare that to the right of that of patients with solid organ transplants, like kidney transplant patients. They have much lower levels of antibodies after vaccination. In the right-hand part, patients on immunosuppressive drugs, for example, cancer patients who are receiving chemotherapy, also have lower responses of antibody to the vaccine. And in the left-hand side, it compares hemodialysis patients to cancer patients. So what you see is, in general, hemodialysis patients appear to develop good responses to these mRNA vaccines. There have been some recent studies showing that there are some differences between hemodialysis patients and healthy people with normal kidneys. So it's not that they're exactly the same, but their antibody levels really are pretty good compared to these other populations. So let's talk about this 3rd dose. There are really 2 reasons that you would want to give a 3rd dose. The first thing we know from the studies that the drug companies did, that a 3rd dose of mRNA that's given at least 6 months after the 2nd dose may increase the level of antibodies 10-fold or 20-fold. That's a huge step up. So we know that for most people, a third dose given after 6 months after the second substantially increases the antibody level. Well, the question is, do we really need such astronomically high antibody levels? There are two groups of people who likely would need that. First is people who never developed enough antibodies to begin with, like people who are immunosuppressed, like those transplant patients I just showed in the last slide. Those people with impaired immune systems, if given a third shot, many or perhaps even most do get antibody levels up to par after getting a third shot. So that third shot is really not a booster for them. It's really to get fully vaccinated. The second group of people who do well are people who've been fully vaccinated, but with time, antibody levels fall. And a booster boosts up those antibody levels back up to effective levels again. All the controversy you hear in the press about when to get a booster really has to do with, well, when does the antibody level get so low that it's time that it needs to get boosted up? And it's not so clear right now. It's early on in this new disease of COVID-19. We'll know the answer to that, 2 years or 3 years from now. But now, what we do know is that there are some people whose antibody levels do fall with time. Eventually, everybody's do, but after 6 months, the majority of people still have really good antibody levels that stay up. And so the thinking is, this is kind of insurance. Why not get that third dose if it is harmless, if it rarely causes any complications? If only 10 or maybe 20% of people have lower levels, why not? We don't know who they are. Let's give it to everybody. And that's the current thinking of how this is going to get rolled out. Well, then how about the J&J vaccine? Because the J&J vaccine is a bit different. Instead of it being a small piece of messenger RNA that gets put inside the cells, a very small piece of the viral DNA. Now, this is not the virus itself. It's not virus that gets put in, but it's a tiny segment of the DNA that the virus uses to make the spike protein. Not that makes the whole virus, but the DNA that makes the spike protein. That's put into a harmless adenovirus, another virus that does not cause disease, but a virus that after injected does get into the cells, allowing this tiny piece of viral DNA to instruct the body's cells to make antibodies. So the viral DNA gives instructions to your cells to make the spike protein. Your body then makes antibody to the spike protein, but the adenovirus itself doesn't cause any disease in the body, and that little tiny piece of viral DNA does not do anything else at all. Both are removed from the body by the body's normal defenses, and you're left with antibody against COVID-19. And it works much the same way as the RNA viruses do, as I just described, injecting that little encapsulated piece of viral DNA, causing your body to make spike protein, and then you develop the antibodies. We know that these vector vaccines, like the J&J vaccine, is safe and effective in dialysis patients. There isn't data yet about the safety or efficacy of a second dose, although, as you all heard, just last week, J&J did publish some data showing safety and likely efficacy. We're all waiting to review those data, but it looks promising that similar to the mRNA vaccines, that the J&J likewise will have a booster shot that is effective and safe. There have been some observations suggesting that antibody levels may be a bit lower using the J&J vaccine than with the mRNA vaccines. So that's something we're watching, yet we know that the vector vaccines like J&J, by and large, produce very adequate levels of antibody for protection. Finally, let me say a few words about the Delta variant, the one that now is the major virus that we are seeing in this country. The first is that it is highly contagious. It's probably twice as transmissible as the original Wuhan strain. In fact, when it's been looked at, the number of virus particles in the airways of people who were infected, the viral loads, are about 1,000 times higher than the viral loads caused by other variants of COVID-19. So the Delta variant is more contagious, is more catchy, and it has many more viruses than the original did. The symptoms it causes are very similar to the original variant, commonly with fever, headache, runny nose, sore throat. Cough and loss of smell are not common in this Delta variant. We're not seeing cough or loss of taste or smell as commonly as we originally did. The Delta variants affect mostly unvaccinated people. If we look at all the people who are infected with the Delta variant, the majority of them are people who have not been vaccinated. They can infect people who have been vaccinated, but largely they're affecting unvaccinated people. And the Delta variant causes similar complications to the original, but hospitalizations, at least in one study, were twice as high as with the original virus. So, to wrap up my comments, here's what my advice is. First, if you've not as yet been vaccinated, get vaccinated now. There's plenty of evidence, and if you really can focus on the facts and what's really known and not on the misinformation that has been around, I think you'll be convinced that you'll be far safer with a vaccine than without. If you have an impaired immune system, or now that it's just been announced, if you're a dialysis patient or over age 65, speak to your doctor about a third mRNA vaccine dose. If you got the Pfizer vaccine, that will be available to you shortly. If, like me, you got Moderna, then we'll have to wait until Moderna's data are out. But people in the know tell us that it's likely a matter of weeks until the Moderna data show perhaps what is similar to the Pfizer data, and that is likely to be available as well. And then finally, the J&J vaccines, as we've heard, they will be submitting their data to the FDA as well. Get your information about the virus from reputable sources like the CDC, local health officials, and your healthcare team, your dialysis nurse, your dialysis physicians. Don't be frightened by misinformation. Stay safe, keep your family safe, and do the right thing for yourself and for your family and for everybody around you. Okay, so that ends my formal comments, and so we do have around 10 minutes or so for any questions that you might have. So Hannah or somebody, will you be reading the questions for me?
Hi, this is Kathy. I will. I do not see any in the chat box as of yet. My sense is everyone was so involved in your presentation that no one wanted to take time to stop and write something down.
Yeah, so we have a relatively small group. So please type in or let us know if you have any questions. There are no stupid questions at all. You'd be amazed what I have found, some very smart people that have real misperceptions about the vaccines and about the infection.
We can give people another minute. If you joined by phone, you could unmute your phone. I think with a small group, you could unmute your phone by #6 to ask a question. Well, there's a question that just came in. Can you see it, Dr. Kleiger?
Yeah, I can. Okay, Stephanie, thanks so much for asking. Stephanie wonders if it's advisable to separate vaccinated dialysis patients from non-vaccinated. You know, the truth is, as we've looked at the data, that the likelihood of transmission in the dialysis unit using what everyone now does, universal masking, personal protective equipment, surface cleaning, and hand hygiene, those are the staples. When that's been done, the rate of transmission in the dialysis unit is virtually gone. It's virtually absent. So we have not been separating vaccinated from unvaccinated patients because the likelihood of transmission in the unit itself is really exceedingly low. Were that not the case, and were there evidence for more transmission in the facility, then that would be a very reasonable idea, would be a very reasonable thing to do. But I personally feel real safe looking at the data from around the country, which suggests that it's very rare to contract this infection in the unit. It is much more common to contract it in the grocery store or in a nursing home, you know, but not in the dialysis unit.
Thank you. We have another person writing in. There you go. Thanks,
Lynn, is there recent research on vaccination success for people who live in nursing homes and receive dialysis in nursing homes? Yeah, right on the heels of what I just said. So we know that, from the epidemiologic work that's been done, that nursing homes are a relatively high source of infection in this country, and they have been, number one, because people are in a congregate living situation, living together, even if people are living in their own rooms with staff that come in and out and with other opportunities for congregating together, that the nursing homes have been a higher source of infection. Also, people in nursing homes are older and have a higher incidence of the very diseases like diabetes and chronic kidney disease that makes them more prone to develop infections. So given that background, looking at vaccination among nursing homes looks similar to what we've seen in vaccinations among dialysis patients, which is that it has very substantially reduced transmission of infections and reduced life-threatening infections.
Thank you. We also, since it's time for flu vaccines, do you want to give the pluses and minuses of doing the booster and the vaccine, or just a regular vaccine and the flu vaccine at the same time? Yeah.
So first of all, it is really important to get the flu vaccine. Before last year, before 2020, if you look at the country at large, somewhere between 25 and 65,000 people each year die of influenza. So it's not a tiny disease. Last year, flu appeared to disappear. We just saw very, very little of it. And not just in the United States, very little of it in the world. And most people think that's probably because everybody was using masks, was socially distancing, was using hand hygiene. All of the things that we do for COVID probably are the same things that helped to prevent the spread of influenza, of flu. But this coming year, everyone is more concerned about it because so many people have gotten tired of the masks and are either not using them properly or not using them at all. And because it's been absent for a year, it well may be that the variety that this year comes along may be a much more challenging or virulent variety than we had before. So taking the flu shot, it really is particularly important this year. You can take the flu shot at the same time or around the same time as the COVID vaccinations. There was a time that the CDC was saying that we should separate them, but the data that the CDC has generated since then and the studies they've looked at show that there's really no problem getting the both of them at the same time or close to each other. So yes, my strong advice is both COVID immunization and that third booster when it's available, and also the influenza or the flu shot.
Great advice. Thank you. Any other questions? Dr. Kleiger, any last words you would like to share?
No, I appreciate the chance to talk. Anytime I can talk to patients and their families or staff, I really appreciate that. So I just want to thank everybody for coming to talk together today. Thank you.
Well, we definitely thank you for sharing all of that information. There's always something new to learn, and I definitely appreciate your spending the hour with us. I want to thank all of our participants for also spending this hour with us, and remind you that next month we will have another topic on building your resilience during COVID. I think, as Dr. Kleiger mentioned, lots of people are pretty tired of masks and pretty tired of COVID right now, but we do need to be vigilant. It's not going away just because we're tired of it. So please sign up and join us next month as well. We will have the slides and this recording available in a few days, sometime early next week. And please fill out the feedback form for us before you sign out. Dr. Kleiger, thank you again. We so much appreciate it.
Thank you. Thanks, everybody. Bye-bye.
Bye. Thanks, everybody.